I want to discuss with you the parotid region, and to begin with, we'll outline the main bony points that come into this region. If we start at the back here, we have the external occipital protuberance, the occipital bone coming down into the mastoid process, and then up here we can indicate the external auditory meatus and show here the tympanic plate, and then show down here the styloid process of the temporal bone. Then we can go along with the base of the skull and show here the glenoid cavity and the eminentia articularis, or articular eminence there. And now we're coming on to the zygomatic process of the temporal bone. Here we'll indicate the position of the head of the mandible and the posterior margin of the ramus of the mandible. Here's the coronoid notch, and here's the lower margin of the body of the mandible. Now the sternocleidomastoid muscle has arisen from below at the manubrium sterni and from the medial one-third of the upper surface of the clavicle, and it's passing up to be inserted into the side of the mastoid process and onto the lateral third of the superior nuchal line. So we can indicate the extent to which the sternomastoid covers the side of the neck, and we'll rub out here the mastoid process and just indicate the shading, the position of the sternomastoid muscle. Now, coming down on the inner surface of the mandible from the medial pterygoid plate is the pterygomandibular ligament, and I'm just going to indicate its position through a sort of transparent ramus of the mandible. And we can show, coming off the front of this pterygomandibular ligament, the buccinator muscle. Now the buccinator comes forward from the ligament, and the fibers extend forward in this way, and also from the margin, the alveolar margin of the mandible, until we get to the region of the mouth. And I'll just indicate the position of the lateral angle of the mouth here, and we can see how the fibers are coming into the mouth and becoming part interdigitating with the orbicularis oris muscle. So this is the buccinator muscle. Attached to the lateral surface of the mandible, we have coming down from this area, from the zygomatic arch, we have the masseter muscle. And the masseter muscle comes down and is inserted into the outer surface of the ramus of the mandible and the junction of the ramus of the body in that fashion. And so we can now rub out the structures that lie deep to there, the ramus of the mandible and the buccinator muscle, and put in the fibers of the masseter muscle or masseter muscle. Now when we think of the styloid process, we should be thinking of the stylohyoid ligament, which passes down here into the lesser cornua of the hyoid bone, and we should be thinking also of the muscles that arise from this styloid process. We have the stylohyoid muscle, which passes down here and goes into the hyoid, splitting to enclose the intermediate tendon of the digastric. The stylopharyngeus arises from the back part of the styloid process and passes down and will disappear between the superior and middle constrictor, and we'll just leave it there for the moment. And then we can put in the front here, arising from the front of the styloid process, the styloglossus muscle, which is coming down and disappearing behind the mandible and will pass down and sweep into the tongue. Now before we go any further, we must put in the superior constrictor. Now the superior constrictor is emerging from behind the ramus of the mandible, and I can just indicate its upper margin sweeping round like this to go into the raphe, which is in the midline posteriorly. So we'll just indicate the outer surface of the superior constrictor coming round in this way. The lowest fibers arising from the lower part of the pterygomandibular ligament and then sweeping down in this way and sweeping round to meet the fellow of the opposite side. And then we can put in here the origin of the middle constrictor arising from the lower part of the stylohyoid ligament and the upper margin of the greater cornua of the hyoid bone, and that sweeps up here like that, overlapping the superior constrictor and the lower margin sweeping down that way. And now we can rub out here the superior constrictor, showing these fibers of the middle constrictor coming around, fanning out as they do so. Coming out of the skull, between the styloid process and the mastoid process, there's a small hole there, the stylomastoid foramen. Coming out of the skull in that situation is the facial nerve. And I'm just going to leave it there, coming forward. So we've now built up the bed for the parotid gland. And to fully appreciate this bed, I think we should pass over to that side of the board and take a horizontal section through this area and put in all the muscles and structures that we've entered into this diagram. Now I'm just going to take a section here across the mastoid process. These are the mastoid air cells. And I'm going to indicate over here the posterior margin of the ramus of the mandible. So this is the mandible. I'm going to put in, here is the sternocleidomastoid, and I'm going to put in on this side the sternocleidomastoid. Sternocleidomastoid, sternocleidomastoid. On the outer surface of the mandible, we have the masseter muscle. Masseter coming down from the zygomatic arch and being inserted into the outer surface of the mandible. Coming down from the zygomatic arch and being inserted into the outer surface of the mandible. Now we should consider a muscle that's lying on the medial surface of the mandible that we cannot see in this diagram. And this is the medial pterygoid muscle, which is coming down from the pterygoid region to be inserted into the medial surface of the ramus of the mandible. So here is the medial pterygoid muscle. And for completion, we can just show here the inferior alveolar nerve going into that foramen there. Now, have we a muscle on the medial surface of the mastoid process? Yes, we have. It is the posterior belly of the digastric. And we'll put that in. The posterior belly of the digastric is attached to the inner surface of the mastoid process and is sweeping down here to its intermediate tendon. So we can rub out the structures that lie medial to it. Here's the anterior border of the sternocleidomastoid, and here is the posterior belly of the digastric going down to its intermediate tendon. Now that's attached to the medial surface of the mastoid process. So we can put it over here to the medial surface of the mastoid process, the posterior belly of the digastric. Well, now we're in a position to put in the styloid process. So we put in the styloid process across here at about this point. And we can indicate the muscles which are attached to it. We have here the styloglossus passing forwards, the styloglossus. We have here the stylohyoid muscle passing from near the tip, the stylohyoid muscle. We have here the stylopharyngeus muscle, the stylopharyngeus muscle. Now, what is lying medial to the styloid process and its muscles? Clearly, it is the superior constrictor. So we can indicate over on this diagram the superior constrictor coming round here in that way. So you see, we now have a triangular area here in which the parotid gland will lie, bounded in front by the mandible and bounded behind by the mastoid process and its associated muscles. Before we put any more in, let us bring up the carotid vessels. We have the internal carotid artery coming up here, passing deep to the posterior bed of the digastric and passing up here in the carotid sheath. And we have passing up in front of it and medial to it the external carotid artery. And this will pass up here, and it'll pass to the neck of the mandible, where it will divide into its terminal branches. The internal maxillary and the superficial temporal artery. So now we can put this in. We have here the internal carotid artery, and the external carotid artery is lying in this region, and we'll show it bifurcating into the internal maxillary and the superficial temporal artery. Now we can bring up the internal jugular vein, and it's overlapping across the carotid, internal carotid artery, lying within the carotid sheath, and so we can indicate this large vein disappearing under the anterior border of the sternocleidomastoid. And having passed up deep to the posterior bed of the digastric, it will of course overlap the whole of this structure here, the internal carotid, and pass up like this in this region. So we can put in here the internal jugular vein cut across. Now whenever you think of the internal jugular vein and the carotid arteries, you should be thinking in terms of the vagus nerve. So there we have the vagus nerve, and we take a section across this in this region. So here we have then the carotid sheath enclosing these structures. All right, well now let us draw in the outline of the parotid gland, how it's going to sit in relation to these structures. It's going to pass into this wedge-shaped depression between the mandible and the sternomastoid. So we must try and indicate the fact that it is passing in here, and as it comes out, it overlaps the surface of the sternocleidomastoid. And it is now coming out here. It encircles the carotid and comes out here and overlaps this region and comes down in this region. Now this is just the outline and the section through it as it's going in here. Now let us go over to the other diagram, and we can see that it'll come in here like this, will overlap forward, come round here, and will actually pass in between the medial pterygoid and the mandible as the pterygoid process, and then it'll pass in like that. So that we're now in a position to put in some of the important nerves that sweep round. Now, for example, here comes the facial nerve. It sweeps around, and it actually divides the parotid gland into a superficial part and a deep part. So here is the styloid process, here's the mastoid process, so this would be the region of the stylomastoid foramen, so here's the facial nerve. And as it sweeps forwards, it divides into an upper and lower part. Now I'm going to indicate those as being side by side. It's a bit of an artistic license, but at least it shows it's dividing into two main divisions. Now this divides the parotid into a superficial part and a deep part. And the facial nerve, having divided into these two branches, emerges on the anterior border. And so we see the facial nerve going into an upper division and a lower division and emerging from the front. And here the terminal branches will be: the lower branch will come down into the neck as the cervical branch, then we shall have a mandibular branch passing forward onto the mandible, and a buccal branch passing forward over the masseter to the buccinator. And then the upper division will come up here as a temporal branch and a zygomatic branch. So the order of things then are zygomatic and temporal zygomatic, and then buccal, mandibular, and cervical. And you will notice that this nerve is lying very superficial in relation to the parotid gland as a whole. Now, are there any veins inside of the parotid gland? Yes, we have the posterior facial vein, which is formed by the union of the superficial temporal vein and the maxillary vein. You remember that the artery here divided into the external carotid, divided into the superficial temporal and the maxillary. Now you have the corresponding vein, the superficial temporal vein and the maxillary vein, uniting to form the posterior facial vein. So we see that the facial nerve emerges on the anterior border of the parotid gland as a number of branches: the temporal, the zygomatic, the buccal, the mandibular, and the cervical branch. And it is this cervical branch which is going down to supply the platysma muscle. It will be appreciated that these nerves are going to supply the muscles of facial expression. I want to draw your attention to a small branch coming off this cervical branch known as the marginal nerve, and this passes up over the lower margin of the mandible and will supply a small but nevertheless important part of the musculature around the mouth called the depressor anguli oris. And should this be unavoidably cut during a surgical operation, this will result in distortion of the mouth. So this is the marginal branch of the cervical branch of the facial nerve.
In the superficial tissues of the neck, one may identify the marginal branch of the facial nerve over the submandibular salivary gland. When the skin flaps are being elevated during operation, the marginal branch of the facial nerve should be preserved. Electrical stimulation helps the surgeon to locate the nerve, so it may be dissected free and protected. Note the contraction of the depressors of the angle of the mouth on electrical stimulation of the marginal branch. Acute injuries of the face, even when they are superficial, may injure specific branches of the facial nerve. This clean laceration across the margin of the mandible has divided the marginal branch of the facial nerve. The diagnosis should be made before any wound manipulation or injection of anesthetic agents is carried out. By asking the patient to smile or show his teeth, one will see elevation of the lower lip on the side of injury as evidence of paralysis of the depressors of the angle of the mouth.
Now, while we're talking about the facial nerve, let's go across to this diagram and put in some more branches of the facial nerve near its emergence from the stylomastoid foramen. Here it gives off a nerve to the posterior belly of the digastric muscle. And this nerve, the same nerve or another nerve arising from the trunk, will pass forwards and supply the stylohyoid muscle. So then the facial nerve gives off these branches before it enters the parotid gland. There's one more branch that passes up here and goes round the back of the ear to supply the auricularis posterior and superior muscles which move the auricle of the ear. Now let us consider the other muscles around the styloid process. We have the stylopharyngeus, and this is supplied by the 9th cranial nerve, which is still lying inside the carotid sheath. We have the styloglossus muscle here, which is supplied by the 12th cranial nerve, but this receives its nerve supply lower down. We have here the sternocleidomastoid, which is supplied by the 11th cranial nerve, the spinal accessory nerve, which, as we've seen previously, crosses and goes through the sternocleidomastoid and also supplies the trapezius. Now let us turn to just a brief discussion of the capsules of this important salivary gland. The salivary gland itself has its own true capsule, which I have indicated in white. Around the outside of this, it has a fascial covering derived from the investing layer of deep cervical fascia. And this encloses the salivary gland in a tough outer covering, which in cases of parotitis is responsible for the tension inside the parotid gland. Incidentally, this part here is particularly thickened to form the stylomandibular ligament, which goes from the back of the stylo process, front of the stylo process rather, back down to the mandible. Lying between the true and the false capsule here, we have some little lymph nodes here, the superficial parotid lymph nodes. So that now we're in a position to put in the skin and the subcutaneous tissue, and to remind you that supplying the skin over this region, we have the great auricular nerve. The great auricular nerve arising from the anterior primary rami of C2 and 3 is passed around in this region over onto the angle of the jaw. The reason I'm drawing your attention to this is that if a child or anybody else gets a penetrating injury, such as a dart, going into the parotid gland from the side, you can see how it's possible to damage the great auricular nerve, which is a sensory nerve here, supplying the skin and the sweat glands, and come right the way through, and also damage the secretomotor fibers coming up from the auricular temporal nerve. And during the process of repair, these two sets of fibers may cross, so that some of the secretomotor fibers may come out into the great auricular nerve and cause sweating every time the person thinks about food.
An interesting anatomical complication described previously by Dr. Snell, called gustatory sweating. On gustatory stimulation, sweating appears in a localized area over the area of elevation of skin flaps for the parotidectomy. This is a result of regrowth of fibers from the auriculotemporal nerve, which normally stimulate parotid secretion, out to the skin flap and to the transected nerves to the sweat glands over this localized area of skin flap elevation. Note the localized production of sweat over the parotid gland area on gustatory stimulation. This is Fry's syndrome, or gustatory sweating.
Now let us complete the rest of this gland. We bring it up and we see that it is snugly passes down behind, in front, rather below here, the external meatus, and comes up here into the region of the glenoid cavity. And a part of it actually tucks into that glenoid cavity behind the joint, and it is this glenoid process of the parotid gland which, when inflamed in mumps, causes difficulty in opening the joint. It becomes painful. The gland then sweeps forward across the outer surface of the head of the mandible and overlaps the masseter muscle and then comes down, and so we have the complete part of the gland. Now it's possible to rub out the structures that lie within the parotid, emphasizing again the importance of that facial nerve lying quite superficial to the deep structures inside the gland. And so we see that it is a triangular shaped structure imprisoned between the anterior border of the sternocleidomastoid, the posterior margin of the mandible, and going up to the external ear, coming across, and then usually extending over, and this part sometimes called the facial process of the parotid gland. Now all that remains to be put into this drawing is the duct of the gland. Now to get the surface marking of the duct, one has to draw a line forward from the lower part of the lobe of the ear to the midpoint between the alar of the nose and the upper red margin of the upper lip, a line drawn from those 2 points. Now we take the middle third of that line. So just to estimate, if here is the external ultrameatus, the lower part of the lobe is somewhere there. Between the alar of the nose and the upper red margin, the upper lip will be a point about here, and we draw a line forward from there. And we see the duct comes forward over the outer surface, lateral surface of the masseter, pierces the buccal pad of fat, which is a little fat here clump lying on the lateral surface of the buccinator, and then turns around and passes medially through the buccinator and goes through the cheek. Now it doesn't immediately pierce the mucous membrane, but passes forward a little way before it enters the mouth opposite the upper second molar. In other words, there's a sort of valvular orifice there, so that every time you blow a trumpet, you don't blow up your parotid gland. It's a valvular mechanism. Now just to go over some of the lobes of the gland. We have here the facial process, and there may be an accessory part of the gland up here with little ducts coming into the main gland. So here's the facial process, an accessory part of the gland, the glenoid process which goes into the glenoid cavity, and here we have the pterygoid process passing medial to the ramus of the mandible.
The surface projection of the parotid duct or Stenson's duct a line between the nasal ala and the earlobe. It enters the mouth where a vertical line from the lateral canthus of the eye intersects this line. We may see the relationships of the parotid duct as the orifice of the duct adjacent to the second upper molar tooth is probed. The parotid gland is reflected anteriorly to show the cervical and mandibular branches of the facial nerve. The main trunk of the facial nerve with its upper and lower divisions. With the gland reflected downward, one may see the terminal branches of the facial nerve, as well as its main trunk. From the upper division, the temporal branches, the zygomatic branches, and from the lower division, the buccal branches and the mandibular branches, as well as the cervical. Note the relationship of the parotid duct. In the neck dissection and superficial parotidectomy, the facial nerve branches are carefully preserved. This is the cut parotid duct. Blue dye has been injected into the parotid duct preoperatively, and it makes the nerve stand out against the deeply stained parotid substance. The zygomatic and buccal branches, the cervical branches to the platysma which have been cut. Now, with electrical stimulation of the main trunk, all of the facial muscles respond. Stimulation of separate branches and response of specific muscle groups. The zygomatic, the buccal, the mandibular and the marginal mandibular, buccal, zygomatic, and temporal. The temporal bone, with its zygomatic process and mastoid process. The mastoid process has been drilled out to show the relationships of the external auditory meatus. Here is the external auditory meatus and its relationship to the inner ear and the semicircular canals. The facial nerve passes adjacent to this area and emerges from the stylomastoid foramen between the styloid process and the mastoid process. In the neck dissection, let's review the fact that all of the branches of the facial nerve are intact. The marginal branch, the buccal branches, the buccal and zygomatic branches, and the temporal branches. After check on the facial nerve and a careful review for hemostasis and for security of ties on the internal jugular vein, we shall replace the skin flaps in our patient who has undergone block resection of the neck contents, the superficial lobe of the parotid gland, and the entire side of the face where the malignant melanoma had resided. Here is the patient postoperatively. Despite the fact that he had a positive lymph node in the parotid area, he is now over 5 years postoperatively with no evidence of recurrence of his malignancy. Note the skin graft on the side of the face at the site of previous malignancy. The lack of full trapezius function has been well compensated for. The patient's facial nerve is fully intact and functional. One may palpate and see the carotid pulsations. Here is the second patient. Note that he also has compensated quite nicely for lack of function of the accessory nerve. He is able to cover the skin-grafted area where his large melanoma resided with his own normal hair growth. The skin wounds have healed kindly, and it is possible to see the pulsations of the carotid. The patient has full facial nerve function, and there is no evidence of loss in function of the hypoglossal nerve. Note that tongue function is quite normal.